Okay, so you're prepping for your anesthesia or critical care finals, and you know there are certain topics that are just guaranteed to show up. Well, acute respiratory distress syndrome, or ARDS, is definitely one of them. In this explainer, we're going to cut right through the noise and give you the essential, up-to-date info you absolutely need to nail those questions. Right, let's dive in. We're going to break this down logically so we can build our understanding from the ground up. We'll start with what ARDS actually is. Then we'll look at who gets it, how you diagnose it, the core management stuff, and finally, we'll wrap up with the key takeaways you'll want to have memorized for exam day. First things first, let's get a really solid handle on the definition. You know, we throw the term ARDS around all the time in the ICU, but what are we actually talking about? Getting this right is absolutely critical. So here's the bottom line. ARDS is this huge, widespread inflammation on the lungs that causes them to fill up with fluid. But the key differentiator, and this is a classic exam point, is that this is non-cardiogenic pulmonary edema. The heart is not the main problem here. So how does this all go down? Well, you can think of it in 3 steps. First, something comes along and injures that super delicate barrier between the tiny air sacs and the blood vessels. This just kicks off a massive inflammatory storm. Step 2, the air sacs start flooding with this protein-heavy fluid and a ton of inflammatory cells. That's why the lungs get so heavy and waterlogged. Now, for some patients, it stops there, but for others, it moves into a third phase, fibrosis. This is where the lung starts to form scar tissue, leading to really long-term stiffness and damage. Okay, so we've got this whole process of injury and flooding going on inside the lungs, but what kicks it all off? To understand that, we've got to look at the typical ARDS patient, who gets it and why. For your exam, you have got to know this list. The number 1 cause of ARDS by a long shot is sepsis. It could be from pneumonia, but really it can be from an infection anywhere. Other big ones are things like aspirating stomach contents, which is just a nasty chemical burn on the lungs, and of course, severe trauma. And, beyond those direct causes, some patients are just more vulnerable. It's like their lungs have a weakened defense shield. Chronic heavy drinking, for instance, is thought to strip the lungs of their natural protective antioxidants. Same goes for smoking. So these patients are essentially primed for ARDS. All it takes is one big hit, like sepsis, and their lungs are way more likely to go down. Now for the really practical part. How do you confidently diagnose ARDS when you're in a busy ICU? Well, it comes down to a really clear, internationally agreed-upon checklist. This is a money slide for your exams. The diagnosis hangs on these 3 criteria from the new 2024 global definition. First, the timing has to be acute, within a week of some known insult. Second, the imaging shows those classic bilateral opacities. And third, the patient is severely hypoxic. We measure this with the PaO₂ to FiO₂ ratio, or PF ratio, which needs to be 300 or less. Now, here's a big update. The new definition also includes the SpO2/FiO₂ ratio. And that's a huge deal because it means you can diagnose ARDS even if you can't get an arterial blood gas, which is a game changer in resource-limited settings. And this right here, this perfectly illustrates that second criterion. This is the classic chest x-ray you'll see in a patient with ARDS. You see those fuzzy bilateral white areas? That classic whiteout look. This isn't just a bit of collapse, it's widespread fluid filling up the air sacs. So this table kind of pulls your initial workup all together. You've got your arterial blood gas and your chest x-ray to confirm the main criteria we just talked about. But look at the BNP. This is your key test to tell the difference between ARDS and a heart failure problem. A level below 100 basically rules out the heart. And of course, you're sending cultures from everywhere to hunt down the underlying cause, especially if you think sepsis is in the picture. All right, once you've made that diagnosis, the clock is ticking. The management is mostly supportive care with a huge focus on one thing: protecting the lungs from any more damage, especially damage from the ventilator itself. Okay, here's the first of 2 numbers you absolutely have to memorize: 4 to 8 mils per kilogram. This is your target tidal volume for lung protective ventilation. And here's the crucial part. It's based on the patient's predicted body weight, not their actual weight. Why? Because your lung size is based on how tall you are, not how much you weigh. This strategy, which was proven in the big ARDSnet trial, is one of the few things we do that we know for sure reduces mortality, just by stopping us from overstretching and injuring the lung. And here is its partner in crime, your second critical limit to remember. Keep the end inspiratory plateau pressure, or P-plat, below 30 centimeters of water. The P-plat is basically our best guess at the bedside of how much pressure is in the air sacs at the end of a breath. Keeping that pressure low, along with low tidal volumes, is the other half of that lung protection equation. So a major intervention you'll see in the ICU is proning, flipping the patient onto their stomach. It can literally be life-saving, but it's not for everybody. So when exactly do you do it? The evidence on this is crystal clear. Prone positioning has a mortality benefit, but specifically in patients with severe ARDS. We define that as a PF ratio of less than 150. By turning them over, we're basically using gravity to our advantage, helping to open up those collapsed, soggy parts of the lung at the back. But it's not a quick flip. They need to be prone for at least 12 and often up to 16 hours a day to really get that benefit. Lastly, let's talk fluids. The lungs are super leaky, right? So every extra drop of fluid you give them risks just pouring into the lungs and making things worse. The big FACT trial showed that a conservative fluid strategy, where you aim for a neutral or even slightly negative balance, leads to more ventilator-free days. The goal is to keep the lungs as dry as you can without pushing the patient into shock. Okay, let's wrap this all up. Let's talk about the prognosis and the absolute must-know points that you need to carry with you into your exam and, more importantly, into your clinical practice. First, we have to appreciate just how serious this is. Even with everything we can throw at it in a modern ICU, the mortality rate for ARDS is still incredibly high, somewhere between 30 and 50%. And it's important to remember, most patients don't die from just a lack of oxygen. They die from the underlying illness or that whole cascade of multi-organ failure that it triggers. So, to bring it all home, here's your final checklist for exam day. Remember, ARDS is non-cardiogenic edema. The diagnosis rests on those three pillars: timing, imaging, and oxygenation. Management is all about lung protection. You gotta know your numbers: tidal volumes of 4 to 8 mils per kilo and a plateau pressure less than 30. Use prone positioning for the severe cases with a PFF less than 150, and never ever forget to aggressively hunt down and treat the underlying cause. All the information we've gone through here has been grounded in the latest May 2024 guidance from BMJ Best Practice. Hopefully, this has helped really solidify these key concepts for you. Thanks for joining us, and good luck with your exams.